Okay, I think we are live.
Hello.
For those people who are live, can you give me a thumbs up if you can hear us?
I'm gonna give you a thumbs up. I can give you a thumbs up.
I see 11 people online. Just checking if everyone can see us okay. Just need some feedback from the audience. Okay. We have 14 people online now. Okay. So welcome everyone today to this live session. We are very excited to invite the professor himself to open up this first live event that's run by the Osseointegration group. And today it's everything about osseointegration. Whatever you want to ask online, send in the comments, and we do have a long list of questions to go through that have been sent by people previously. Before we jump right into the questions, let's let the professor give us an introduction to what osseointegration is. So go ahead.
Thank you, William. Good evening, everybody, or good morning, wherever you are around the world. My name is Munjed Al Muderis. I have a great deal of passion about osseointegration surgery, which is a technology that is very innovative, and it should change the way we rehabilitate people who lose limbs. Osseointegration surgery, it's a technology that involves, for people who don't know what it is, it's a technology that involves directly attaching a highly tensile strength titanium implant into the residual limb, particularly the bone of an amputee, and connecting it through a small opening in the skin to a prosthetic limb. It does revolutionize the way we manage and rehabilitate amputees dramatically. Over the last 600 years, we've been managing people who lost limbs with a traditional socket-mounted prosthesis, which is like a bucket that wraps around the leg, and that technology hasn't changed. Over the last 20 years, osseointegration surgery become more prevalent, and it's gaining significant amount of attention from all around the world, and there is a lot of talk about it, and lately there has been a lot of controversy about it because it's a new technology. It shakes the way we rehabilitate amputees, and there are many questions that are asked about this technology. There are a lot of myths, there are a lot of facts, and there are a lot of feelings about osseointegration. You have the yay sayers and you have the naysayers, and people can be very passionate about either way, and but hopefully with time the cloudiness about this technology will dissipate and people will see it, because the vast majority of people who have used it have benefited from it and believe in it. It does, the main aim of osseointegration surgery for amputees is to improve mobility. This is a mobility improvement technology, allowing the patient to have more freedom of movement, allowing the proximal joint to move better, allowing the patient to have a gait cycle as close as possible to normality when comparing to the old-fashioned traditional socket-mounted prosthesis. I've been criticized about criticizing the socket-mounted prosthesis, and in all fairness, the socket-mounted prosthesis is a very average technology that has not evolved with time, and we still see patients suffer when they use it. So by directly attaching titanium implant into the skeleton, you will restore the mechanical access of the limb, and you would allow the patient to have a better gait cycle as close as possible to normality. When it comes to above knee amputees, it improves dramatically their movements, reduce their energy consumption. And when it comes to below knee amputees, it is, in my opinion, way superior than many other limb salvage modalities such as ankle fusion.
Hmm. So, taking a step backwards, be more general. Who is eligible? Who is the good candidate for osseointegration patients?
So this technology is a solution for people who have significant mobility issues, whether they are an amputees struggling with a socket due to problems with friction, problems with liners, problems with sweating, problems with fatigue, or whether they're having problems with the socket due to poor fitting of a socket, or whether they have problems with proprioception or stability and balance. Um, Also, particularly patients who have higher level of amputation, short residuum, where a socket cannot be fitted. A lot of patients who get rid of the socket and end up in a wheelchair, they may benefit from osseointegration. They may be able to regain the ability to mobilize. That's one category of patients. The other category of patients are people who have still have got their limbs, but for one reason or another, they can't walk. Either they have chronic osteomyelitis in their limb, significant deformities that are not correctable, people who have fusions of their joints, such as knee fusions or ankle fusions, and people who suffer from complex or regional pain syndrome that cannot mobilize with their own leg, and amputation may be necessary for them. So these categories of people that would benefit from osseointegration surgery. Also, um, I categorize patients into different groups. There are patients who definitely would benefit from osseointegration surgery, and these are the patients who cannot walk, and traditional soft mouth prostheses are not suitable for them. There is another category where patients who are walking but they're struggling with whatever they've got, either a socket mounted prosthesis or a limb that is not functioning well. And these patients can benefit dramatically from osseointegration surgery. And there is a third category of patients where patients who are functioning well with a socket mounted prosthesis, there is a question about whether they would benefit from osseointegration and whether the benefits versus the risks, and the risks um, uh, the benefits justifies the risks that you go with another operation. There is a fourth category of patients, and these are the patients who are not willing to improve, and they have a significant psychological issues with their mobility, and no matter what you give them, they can't benefit from any technology. And these are the category of patients where they need significant amount of counseling, significant amount of rehabilitation mentally and psychologically before they embark on any technology, whether it's a socket mounted prosthesis or it's an osseointegration technology.
Hmm. Thank you. So that captures osseointegration as a whole quite nicely. Can you basically tell us right now? I think most of us are aware that you mainly do single stage only. Is there any particular difference between single stage and two stage? Can you tell us, our audience?
So this is a very, very sensitive subject. When I first started doing single stage osseointegration, everybody told me that I was crazy because the risk of infection will go higher and people will have a lot of complications. And then all the naysayers now are doing osseointegration surgery in single stage. We compare the work that we have done with the opera system, for example, where there is a very lengthy rehabilitation period, extend to almost 18 months, two-stage surgery, 6 months apart between stage one and stage two. Um, this, though the system works, it is a very significant lifetime of a patient to go through the process and then may see the results of it after 18 months or even after 6 months. By doing single stage surgery, um, the the way I thought about single stage surgery is to make the implant robust enough to take on single stage surgery. Second, modify the surgical skills and the soft tissue management in order to allow single stage surgery. By combining these two efforts and providing a proper rehabilitation program that allows single stage surgery, we embarked on doing single stage surgery. And from the data that we collected, the first 100 patients that I've done, or first 95 patients that I've done, were two-stage surgeries, and the last over 900 patients, over 1,000 patients now that we have done were all single-stage surgery. When we compare the results of these two cohorts, it's very clear that in my hands, the single-stage surgery is way superior to a two-stage surgery. The complication rate is way lower with single-stage surgery in the cohort that I've reviewed. The infection rate is way lower. The risk of reoperation is way lower, and the patient satisfaction is way higher than two-stage surgery. This technology follows what the dentists have done. I have a dental implant inserted in me, and that dental implant was done through single stage surgery. When dentistry started doing implantation, it was two-stage surgery. And now you rarely see any dentist that does tooth implants as two-stage surgery. And we're no different to dental implant. The mouth is the dirtiest part of our body, and it carries the largest number of bacteria, the more virulent bacteria, and still it is amenable to single stage osseointegration tooth implant. So the limb is much cleaner than the mouth, and I don't see a reason why we still resist doing single stage surgery and osseointegration for amputees.
I guess as you learn from experience, you start developing the technique in a more mature state as well.
Well, basically, I was handed over this technology basically on a silver platter because I learned from the Swedes and learned from their positive points and negative points, and I learned from the Germans again the positive points and negative points. And by developing our system, I combined the benefits of both systems: the press fit, the titanium, the high porosity of coating, and the surgical technique. We developed them in a way to be compatible with taking on single stage procedure, and now the rest of the world follows.
Yep, I can see that as well. So, thanks for the introduction to Osseo. I'm sure everyone online would have a clear picture of what it is now. We're going to turn our attention to the questions that we have gathered in the past few weeks. So, we'll start with the easy ones and more generic ones. Is the surgery painful?
There is no surgery that is not painful. When you go through surgery, you go through pain. Basically, the surgery will involve cutting the stump and reaming and boring the bone, and then press fitting an implant inside. However, the surgery is done under anesthetics, so while the surgery is happening, the patient would not feel anything, and it is paramount that anyone conducting the surgery should have a multidisciplinary approach. You need to be full team of clinicians. We have psychologists on board that helps with the psychology of the patient. We have pain specialists on board. We have anesthetists who practice pain management, and we emphasize a lot of effort and we put a lot of weight on the pain management before, during, and after the surgery throughout the rehabilitation period. This procedure is no different to any major orthopedic procedure. However, added to that, you have uh, the amputation factor, where there are nerves that are very excitable and they can cause neuropathic pain. So, very often, and most of the time, I do nerve surgery at the same time doing the osseointegration surgery. So whether it's
Mhm.
RPNI or TMR, we do it at the same time as doing the osseointegration surgery, and that is to reduce the effect of the neurectomies and the effect of the nerve damage that happens as a result of the surgery. This will be in combination of inserting nerve catheters, doing epidurals, putting patients on oral and intravenous and combination cocktails of pain management that will go for a period of time extending 6 weeks, 3 months, and sometimes for the lifetime of the patient in order to help them with their pain management. A lot of these patients that come to see us are patients who are chronic pain patients or pain sufferers, and the procedure that we perform on the nerves help in helping the reduction of the phantom pain, reduction of the neuropathic pain that these patients have. But that is an adjuvant therapy to the particular osseointegration surgery on the bone with inserting the titanium implant. So the osseointegration surgery itself is for improving the mobility, while the nerve surgery is for improving the pain. And
Mhm.
we need to this always um, uh, uh, take this as separate management that is done combined in the same setting. But it's very important that the patient, when they come to see their clinician, to know that the difference between nerve management and osseointegration management, because osseointegration does not help with improving the neuropathic pain. It does eliminate or help eliminating and reducing the socket-related pain issues, and it does improve the mobility for the patient.
Excellent. So Munjed, I'm gonna get you to scoot a little bit closer to me.
Okay.
Yeah, people have trouble seeing you on Instagram
Okay. I'll
apparently.
get there.
Okay.
That
So I think it's good.
Mhm.
So while we're on the topic of pain, there's a question regarding CRPS. So there's a lot of people who I guess we put on Instagram and social media that they have benefited from osseointegration and they were previously a CRPS patient. Can you comment on how this works?
So CRPS, or complex regional pain syndrome, is a major dilemma for all clinicians. That include the psychologists, including the pain specialists, the surgeons, the physicians. Unfortunately, it can be carried on as a stigma by many clinicians. I've discussed this CRPS issue with surgeons who don't believe that it does exist. Even physicians, sometimes they don't believe that it does exist. CRPS is a real thing. We don't know a lot of things about CRPS. Um, if someone tell anyone that they master the management of CRPS, they would be lying, because CRPS is a very complex problem. A lot of the time, CRPS can present itself in the form of lack of mobility, significant intolerance to any kind of tactile heat, any kind of stimuli on the patient, and a lot of patients with CRPS suffer for a very lengthy time before they get acknowledged and they get diagnosed and they get treated. The treatment for CRPS is still ambiguous, and I have initiated the first steps in establishing the CRPS international unit, which will be a multidisciplinary unit that is run by multiple clinicians that are expert in CRPS and pain management issues. And in order to find an algorithm and identify a way that we can manage it from the neurological point of view, from the psychological point of view, pain management point of view, surgical point of view. And our first inauguration meeting will be held in the coming week or two. That doesn't mean that we don't manage CRPS. We are currently managing patients with CRPS. I have several patients that I've treated with CRPS, several patients that have benefited from the treatment that we offered. I'm proud to say that the vast majority of our patients have either cured or reduced the pain from CRPS dramatically. There are certain small number of patients that we couldn't resolve all their problems, and there are a couple of patients where they had other issues that risen up after we treated their CRPS issues, and such as restless leg syndrome, for example, and we're still investigating and trying to figure out a mechanism and a way to treat these patients. It is it's a lengthy treatment program, and it is not a one surgery that can fix that, and it's not one medication that can fix that. It may, most of the patients with CRPS that I have treated required multidisciplinary approach, required multimodal treatment, including pain management, nerve stimulators, amputation, osseointegration, etc.
So it sounds like you're getting some tractions to such a complex disease.
Well, but we have the only publication about amputation as a result, or as a solution for CRPS with combination of osseointegration, and I have one of the people that I work with is doing a PhD on it, and the study continues, and we all are learning from it. The more we see patients, the more we get experience, and the more we are able to help other people, and from the experience that we gain from treating people before that. And it's a continuous process.
Okay. So taking a step backwards, some more general questions from the audience. So this is a question about amputation. How long between the amputation and osteo is ideal? Is there an upper or lower limit?
So this is a very important question, because again, this is another area where I was criticized very heavily about it. There is no timing between amputation and osseointegration. You look at it from two different aspects. From the physical aspect, the best time of doing osseointegration is the time of the amputation. So physically, you would be able to rehabilitate the patient to the best if you amputate and osseointegrate at the same time, because their muscles will not waste, and they will not learn the bad habits of the socket. That's from the physical point of view. From the psychological point of view, it's a completely flip of the coin, where it is a disadvantage for patients to have amputation and osseointegration at the same time, because psychologically they may not be able to assess and appreciate the effect of amputation on their life. If you get a patient that gets an amputation and they wear a socket and they suffer with the socket, they appreciate osseointegration way more, because it's a jump from having a normal leg that got injured, and then you go to an osseointegration, which is definitely inferior to a normal leg, um, when you compare it to a socket that is way inferior to osseointegration in the mobility, from the mobility perspective. So ideally, if a patient comes to us for assessment, we need to properly and thoroughly discuss with them the options. And I have patients that have chosen either way. Some patients chose to have osseointegration straight away, and some patient chose to have an amputation socket and then come back for an osseointegration after a year. So for people who do not appreciate osseointegration straight away, it is not unreasonable to consider a socket for a year and then see how they go with the socket. And then if they choose afterward to go back to osseointegration, they would appreciate osseointegration much more, because they see the difference between a socket mounted prosthesis and osseointegration.
So in this case, there's another follow-up question on this. If someone says they never really had an issue with the socket, then What do you recommend in that sense?
This fall into the third category of patients where it's a choice for the patient. And I see patients who are athletes, who are high performing people, and they just want a better quality of life. So ultimately, it's a patient choice with what they want to do. We can advise them as long as they have enough enlightenment and orientation and acknowledging all the risks that they will face with osseointegration versus the benefits, and weigh and balance the two. And if they choose to go with osseointegration, then it's fine.
Mm-hmm.
Uh, People choose to do many things in their life that may not be necessary. So there are categories of patients that osseointegration become a necessity for them, and these are the patients that cannot mobilize with a socket. Um, the other category where people who are functioning and functioning well, it is not a necessity, but it's a reasonable thing to consider. Um, I've done a study and I have a paper that we are submitting now, comparing different modalities of rehabilitation, and that include wheelchair, socket-mounted prosthesis, osseointegration, growing a limb, or grafting a limb from another person. Obviously, the last two, growing a limb and grafting a limb, is science fiction kind of theoretical thing that hasn't happened yet. So comparing the three technologies, wheelchair, socket, and osseointegration, wheelchair win in all of the aspects.
Mm-hmm.
Comfort, lower rate of complications, and ease of mobility, and cheap. But wheelchair does not allow the patient to stand. Wheelchair does not allow the patient to walk holding hands with their partner. And this is a very important point. Osseo wins second and socket loses in all the other aspects because it has more problems, lower mobility, but it is the traditional way of doing things. That doesn't mean that it should stay the way of doing things.
Mm-hmm. Okay, so looking at the list of questions that are coming in, I'm going to turn our attention towards something after the surgery. So, can you briefly describe what kind of maintenance is required after a patient goes through osteo?
So it is a lifetime. When you have an amputation, whether you use a socket, whether you use a wheelchair, whether you go with osseointegration, it is a lifetime maintenance that is required. Uh, if you are a wheelchair bound patient, you need to change the wheelchair every now and then. You need to upgrade your wheelchair. You need to change the tires. You need to change the batteries if they are electric. You need to change, replace them. Same thing with the socket. You need to change the socket often. When they get older, you need to change the prosthesis. With osseointegration, there are components that you need to change as well. And these are the components that are external. Um, Anything external to the implant will require replacement on intervals. The dual cone, which is the connector that connects the implant to the external environment, um, has a warranty of 2 years. After 2 years, it is recommended that they get changed. That doesn't mean that they require to be changed, but it is recommended that they get changed because there is a risk of fatigue, metal fatigue, and cracking and fracturing. The connector that connect the implant to the prosthesis require changing as it wears and as it fatigues. And the prosthesis that they wear, whether it's an above knee prosthesis or a below knee prosthesis, that require changing based on the time frame for it. If you look at a lot of the companies that manufacture myoelectric prosthesis, they have a warranty of 6 years, and interestingly enough, they have a some of the companies have default switch internally that will switch off and the prosthesis stop working basically. So you can't service it beyond 6 years.
Mm-hmm.
So unfortunately, It is not like changing your shoes. It is more involved in changing prosthetic components, whether it's the socket, whether it's the osseointegration connectors, or whether it's the wheelchair components. Like anything else in life, you change cars, you change tires. This will require changing as well.
And for the prosthetic side, you recommend people to go to their like certified prosthetist. What about for regular surgery checkups? Do they come and back and see you
So
regularly?
with regards to the prosthetic components, they need to they have a point of contact with the regular prosthetist, and the prosthetists have access to the components, whether it's a socket, whether it's a wheelchair, whether it's the osseointegration components, and we continue to train people on utilizing and using the osseointegration products. With regards to the implant itself, with regards to the stoma, with regards to the stump, with regards to the neuropathic pain, that requires follow-up by a physician or a surgeon, and you need to see the pain specialist, you need to see the surgeon, you need to see your regular GP, and whoever you're familiar with at your first point of contact. Usually, the first point of contact is the general practitioner, um, and the way our protocol work is that we see the patient at week 1, week 2, week um, 6, 3 months, 6 months, 1 year, and regular intervals of yearly after. For international patients, when they go after six weeks back to their home country, they get follow up locally by the local physician, unless there is a major problem that may require for them to contact us or come back to see us. But a lot of the time, majority of the issues that they face can be managed locally at their home country.
Hmm. So on this topic, can you comment more on what kind of hygiene routines that the patients will need to go
With
across?
with regards to osseointegration surgery and the stoma itself, common sense prevails. All the patient need is daily wash. You brush your teeth. You just clean your stump as and the stoma as you have a shower. Warm water and soap is more than sufficient in most of the times. In the presence of granulation tissue, which can happen, depends on the activity level of the patient, that may require further involvement, maybe with the GP or the local nurse or the specialist surgeon, and may require either treatment with oils, silver nitrate, or surgical excision. With regards to infections, that may require, if it's a superficial infection, require oral antibiotic on intervals, intravenous antibiotic, surgical debridement, or if it's deep enough and it's more problematic, may require replacement of the implant or further surgery.
Hmm. So taking a step back, the recovery process. So there's a couple of questions that we got online. People want to know what the recovery process looks like. How long does it take to for them to go back to work? And also there was just one online saying that how what does aftercare look like, and how do we make that part better?
So the surgery is done as one operation. The patients stay in the hospital for a few days. Then they go to either rehabilitation or they go back to their hotel and they come and do the outpatient rehab as an outpatient. The loading process commence day 1 after the surgery. By the first week after the surgery, the patient is allowed to have a shower and wet it. I take the dressing down after 2 3 days and leave the dressing off to air out the skin and the wound and the stoma. The um, loading protocol is divided into slow loading protocol and fast loading protocol, and that depends on many factors. One factor, if it's a below knee amputee, above knee amputee, if it's a long below knee amputee, short below knee amputee, if it's elderly patient, younger patient, if it's an osteoporotic patient, non-osteoporotic patient, if it's intraoperatively stable implant, if it's not very 100% sure about the initial stability of the implant, Ideally, the patient should wake up from the surgery with a stable implant, but sometimes there is things that can happen intraoperatively, that a crack to the bone can happen that may delay the loading. So overall, patients should put in their mind that they need to be loading over a period of 6 weeks, get fitted after 6 weeks, and then the first 3 months walking with two crutches, single crutch, and then unaided after. If it's a patient who is very solid build, transfemoral amputee, very well fitted implant, then they can load over the period of 2 weeks and then get fitted and then walk with two crutches after 2 weeks. So, but if a patient is elderly, short, below knee amputee, osteoporotic, or if there is a crack that happens intraoperatively, then the period can extend to 6 weeks to 3 months. Return to work, office work, patients can return to office work around the 6 weeks mark. Um, if it's a manual laboring or more physical work, I would give it 3 months before they return back to work.
Mm-hmm. Mm-hmm. So on the questions of components, we have a very direct questions here. I'm guessing it's an existing patient. My dual cone is 5 years old. Doesn't need to be replaced.
Yes, definitely. It is recommended to replace the dual cone after 2 years, because replacing the dual cone after 5 years takes a very quick trip to the operating theater or to your prosthetist, depend if you are international or local. It will be done within minutes, and you can go home with a new dual cone without any problems. If the dual cone breaks, then replacing it can take very long time, and it can take hours to replace it under anesthetics. And we have developed new devices to disengage the dual cone, and it is very successful, and it can be done very quickly and very efficiently and without causing any significant discomfort to the patient, and it can be done while the patient is awake, but I prefer to do it in an operating theater rather than in the clinic setting. It can be done in the clinic setting. There is no problem with that. It depends on the patient preference, but and the clinician preference.
Mm-hmm. Mm-hmm. So that's you covered the dual cone and the connectors. Another questions from the audience is how long does the implant last?
Well, the implant, we don't have long-term results so far. The first implantation that I made was in 2009, and the patient have fractured the implant. That was a German implant, the old ILP implant. The patient fractured that implant after 10 years, and we replaced it with a titanium implant, and it's been going since very successfully without any problems. But there are other patients who I have done over 15 years ago now, and they have been going well without any problems, even with the old German implant. To this date, touch wood, I haven't had any of my titanium implant, the OPL implant, that have fractured yet. Um, so it is like a telegraph pole. If you don't hit it by a car, or if it doesn't rust, it shouldn't fall apart. The longevity of the implant depends on the way you treat it. If it fractures the bone, if it becomes loose due to infection, that's when it needs replacement. But the implant itself, longevity wise, it should last very long time. We run our implants on 10 million cycles, and that is equivalent of the basically the longevity of a lifetime. But I can't tell how long the implant can last.
Mm-hmm.
In theory, it should last very long time.
Mm-hmm. So circulating back, we have a few questions that are touching on the indications. Um, the first one will be how long does your residual bone need to be?
Well, the shortest residual bone that I've done was like 1.5 centimeters in Delphine. We had to lengthen her bone, but that's the extreme complexity of patient. The length of I've done a primary osseointegration surgery on a patient with 12 centimeter in the femur, and I've done it primarily on a tibia that is 5 centimeters. Um, but we have the availability of lengthening of the bone for patients who have very short residuum and that cannot be fitted with a standard implant or a customized implant. And we have published more than 2 papers now on lengthening of residuums with the follow-up of osseointegration successfully. And I have several patients that are walking around after I lengthened them and performed osseointegration for them.
Mm-hmm. Okay, so touching on this, we also have a question from Alicia online. What are the contraindications? Specifically, this participant is asking about her brother who had an infection. Can you give us an overview on the contraindications for osteo and whether infection affects that?
Well, infection is not a contraindication. As a matter of fact, infection of bone is an indication for osseointegration. Um, um, when it becomes an intolerable infection, I've treated many infected joint replacements, ankle replacements, ankle surgeries that required amputation and then osseointegration surgery, as long as you cure the infection. So this can be performed as staged procedure where you do the amputation, cure the infection, and then do the osseointegration, or you can do it as a single procedure where you go above the infection level and then osseointegrate the patient with a clear margin from the infection.
Mm-hmm. So
The
what?
presence of an infected bone um, is not the question. The question is whether you are capable of eradicating the infection or not. And in the vast majority of cases, the infection can be eradicated, and we have managed to do so successfully in many occasions. I have the data that shows that we have over 50 cases that we have done that were amputated as a result of an infection in the bone.
Mm-hmm. Can you also comment on the general contraindications, the other
So
things to
the
consider?
general contraindications, again, we started doing osseointegration on smokers. We started doing osseointegration on people who have been immunocompromised, and we started doing osseointegration on patients who are dysvascular, such as diabetics and vascular paths. And I am publishing a paper on the 10-year follow-up of a vascular path patient. We published the same results in 1 year, 3 years, and now 10 years. The patient survived, and they are still functioning, and they're still um, 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 mobilizing in the community. It is very interesting to show that from the cohorts and the database that we collect about these patients who are immune compromised and who are vascular, there is no difference between them and healthy individuals when it comes to complications and failure of the implant. And the reason is it's very simple, because vascular path and diabetic patients, they just want to walk. They don't want to do extreme activities. While the young, healthy adults, they would do more activities, so they are more at risk of having complications. So it balances that. And the lower level of activity um, kind of covers for the problems that the patients have with diabetes or immune compromise or this vascular disorder. So in my books, vascular path, diabetes, smoking is no longer a contraindication. Irradiated bone is a contraindication. Patients who are pregnant is a contraindication, so they need to finish their pregnancy. Patients who are receiving active chemotherapy is a contraindication until they finish the chemotherapy. Patients who are severely immune compromised with double transplant is a contraindication. However, I was proven wrong because I rejected a patient who was double kidney and pancreas transplant, and the patient was done elsewhere successfully, and the patient survived osseointegration. So and I rejected that patient basically because in my books it's a contraindication. But the main contraindication for osseointegration is patients who are mentally and psychologically unstable. Patients who do not understand and do not follow protocols are the ones that are contraindicated. And that falls into the category number 4 of patients that I see, that are patients that have extremely high expectations and do not follow and do not understand the protocols, and they don't look after them. You need to be provided with this technology, um, but you need to appreciate it, and you need to understand that it is not the responsibility of the clinicians that look after you to look after it. It is your responsibility at the same time as it's the clinician's responsibility. It takes 2 people to make this successful. You are one of them.
That's a very good point. We also have one particular question from Almadi online. His question is very simple. What if the surgery didn't work out? What is the plan B?
Yeah, so I had several patients that the surgery didn't work out. I had patients who um, came from America, and for example, on the just before they flew, when we fitted them, the implant become loose. So you do it again. And you have to go back, and in these particular patients I had to cop the expenses. I didn't have to, but it is a risk. But I honored these patients, and I had to redo it again. I had local patients who at 6 weeks mark they got infected and the implant was loose. I have one particular patient that the implant got loose twice. And the third time it worked. So you keep doing it again until it works. But this is a very small percentage of patients, and it's very rare that the implant doesn't work more than once. It's one case out of the over 1,000 patients that it failed twice in a very short period of time, and eventually we and to this day I don't know why it become loose twice. Maybe the first time I undersized the implant, but the second time we put a very big implant and then it become loose again, which was a big shock to us. But if it doesn't work, you put it again. If it doesn't work and continues not to work, which haven't happened yet, you go back to a socket, basically. And I had patients. I had few patients who the implant got infected, and they chose to take it out. We didn't. They didn't lose any much of their bone, and we closed the wound, and they went back to a socket, and they're functioning with the socket. I have one particular patient who went into the Paralympic, won medals in the Paralympic and Invictus Games, and then removed the implant, went back to the Paralympic and won medals in the Paralympic and the Invictus Games with a socket.
So we're talking about athletic performance here. Are any activities actually off limits?
I used to say that running is off limits, but now we don't stop anyone from doing whatever they want, as long as a period of 1 year has passed and the implant is stable enough after 1 year. After the year, they can do whatever they want, because I had several patients that are still, despite us discouraging them from doing any high impact activity, they've done CrossFits, they've done running, they've done Ironman, all sorts of things. I have patients that climb mountains. It is the patient choice. If they do want to take the risk, it is their choice. So I stopped saying that you're not allowed to do certain activities, as long as in fairness, the implant is very robust, and once it's integrated with the bone, the external components are more likely to fail rather than the implant bone interface failing.
So as long as the external components are regularly maintained, there shouldn't be a limit.
Yeah, it should be fine. After 1 year, I think they can achieve full consolidation, and it will be reasonable to basically move on with their life and perform the activities they want to do.
So we also have a few questions online just came through. A reminder, if you have any more questions, we have a few, around 10, 15 minutes left. Drop your questions into the comments and we'll try to push it through. On the topic of activities, swimming, can you comment on that?
So I encourage people to swim in salted pools or the ocean as early as 3 to 4 weeks after the surgery. I discourage people to swim within the first year in chlorinated pools. After a year, they can do whatever they want. So swimming in a chlorinated pool, public pool, is discouraged for the first year. After that, once they reach a stable stoma, they can swim in a chlorinated pool. But for a salted pool, they can swim as early as 3 to 4 weeks after the surgery.
So Darren has a very particular question here, and so this is gonna sound like a bit like a consult. He has a very short femur left, and he's asking whether it'd be more beneficial to remove the femur to start from scratch, or maintain the femur and grow it from there.
Hi, Darren. Look, the advice that I give, if the bone is functional and if the integration is successful, then keeping what you've got is much better than starting again, because every time we start again, we run the risk of losing more bone. And it is a fact and reality with revision surgery. Every time we revise, there is a risk of losing bone. Having said that, starting again is not impossible, but it takes very lengthy time. Lengthening the bone takes 1 millimeter a day, and then consolidation. So if you want to lengthen 10 centimeters, it takes 100 days, and then consolidation 200 days. So if you are ready to go in a wheelchair or walk with crutches for 300 days before putting a new implant in, then it's a choice that you want to take, and we're happy to help you with that. But it is not a risk-free procedure, and it is um, um, a procedure that may not guarantee that you will be able to have osseointegration again or having a socket again. It is paramount to know that if you have a functioning limb, to continue with it and continue strengthen what you've got and even up eventually. I have several patients that have different level of amputation, several patients that had revisions and have different level of stumps and are functioning. Obviously, if it becomes difficult to mobilize and if it becomes a serious impediment, then we can consider lengthening of the bone as it exists without removing the implant. That is an option, and it can be considered. There are other options that are available. You don't need to remove the implant necessarily to lengthen. You can do the lengthening if there is a space above the implant, and that can be discussed. And I'm happy to discuss it with you in a consult. I would recommend that you come and see me again, and then we can have a chat about it.
So, jumping topic here, is osseointegration possible for upper limb?
Yes. The upper limb patients are a different cohort of patients. With lower limb, you have to walk, and that's why it's more necessity for lower limb to have a solution, whether it's a socket or an osseointegration, in order to walk. With upper limb, a lot of patients become dexterous in the other limb, and they get rid of the socket. And that's why upper limb patients, though they are not necessarily less number of patients, they don't go to their prosthetist because they don't use a socket. And when it comes to osseointegration, again, it's because the prosthesis and the connection between the prosthesis and the brain, functionally, it's still clunky. and it's still not very responsive as one wanted. I am embarking on doing an implantable electrode for the first time in the Southern Hemisphere, or the second patient in the world, very soon on an upper limb patient. And hopefully that will open a horizon for us to have this option available, because the surface connectors and the surface electrodes are very, very problematic. And the contact between the surface electrodes and the myoelectric prosthesis, and the pass of the signal, in the transmission of these orders can be an issue, and that's why patients get very frustrated with this. Um, we do have several patients that are upper limb that are functional, but we have some patients that have chosen to remove the implant and just move on with their life, unfortunately. Um, um, but it is the problem that we have with the connection.
Mm-hmm. Mm-hmm. So it's not so much the orthopedic side; it's probably more the prosthetic side of
The
things.
osseointegration side is no different to the lower limb. The integration is the same, and the success rate of integration is similar to the lower limb.
Mm-hmm.
It's the functionality of the limb after the osseointegration, and trying to utilize a myoelectric prosthesis. This is where the difficulty is. And added to that, unfortunately, with the lack of the numbers of upper limb prosthetic users, that comes with a reduction in the experience of the prosthetists that are familiar with managing upper limb patients. So that comes hands in hands, and as a result of that, um, it is problems for patients with upper limb to find a prosthetist that are experienced enough to deal with upper limb prosthetics and to manage it properly. So that creates a bigger dilemma.
Okay, so hope that answers the questions. We have one question that I kind of skipped over, but I think it's important, so we'll come back to this. Infections, how common is it, and should patients be worried?
Yeah, I mean, um, in for people that have seen the court case that is gone and finished. I've been criticized for saying that infection rate is 100%, and I've been criticized for saying that the infection rate is low. So I don't know where to stand here. I can only go by the literature and what we published. Infection rate is around 34% in our cohort. In the opera system, the infection rate is around 55%. That infection is superficial, can be treated with oral antibiotics. To a lesser extent, around 5% people may need intravenous antibiotic or surgical debridement. Um, for people to have the implant removed or replaced and revised, in the single stage surgery for the transfemoral amputees, it's around 3%. Um, for transtibial amputees, it's around 9%. From the patients that we treated. That's over the period of their uh, registration and follow-up. So you can gather from that that the infection rate in the vicinity between 3% to 10% that are serious, and 30 to 40% that are superficial and not serious. Um, and the difference between the two, the not serious infection, which is superficial infection, can be treated with oral antibiotics. The serious infection may require surgical debridement or removal of the implant and coming back again. When you get an infection in the implant, and if the infection is in the bone and osteomyelitis occurs, osteomyelitis is not the end of the world. It can be cured. You can remove the implant if the infection is not treatable, and then put an antibiotic spacer for 3 months, close the wound, and then come back again once the infection is eradicated and put a new implant in. We have several patients that have had revision surgery successfully and have moved on with their life without any major problems.
Mm-hmm. Mm-hmm. So we're gonna jump topic once more. We're getting very specific questions coming in last minute. a patient asked here that the stoma around the implant has leaked since the surgery.
Yes.
And would this eventually stop, or is there something that we can do for it?
Stoma leakage varies from one patient to the other, varies from one location to the other. You have the higher level of amputation, the more leakage happens. The bigger the redundancy of tissue, the bigger the soft tissue mass, the more chance of leakage of the stoma. Below knee amputees have less chance of leakage than above knee amputees. The presence of infection increases the leakage. Certain dairy products intake can cause more leakage. People who drink beer more can cause more leakage. People who are on diuretics can have more leakage. Leakage vary from one individual to the other. Males have less leakage than females. All of these are factors that play a role in the amount of leakage, and the consistency of leakage, the color of leakage, the smell of leakage. Hygiene is very important, and using certain kind of topical measures is very important as well. Leakage can vary from few wet droplets every week or so to someone that change multiple pads every day. And that is unfortunately unpredictable. It can be reduced by reducing the size of the soft tissue envelope, by reducing the weight, and by shrinking the subcutaneous tissue. All of that can play a major role in reduction of the leakage. But unfortunately, leakage, granulation tissue, the development of neuromas, all of these are things that can very difficult to predict before the surgery, and but people need to take into account that this may happen. And from my experience, I've noticed that if I reduce the soft tissue envelope, if I encourage the patient to lose weight, and if the patient change their lifestyle, as in drink less beer, drink or have less dairy product, they get less and less leakage often.
We have one question about age limit.
Yeah. So age is not a limit. Basically, I've treated people who I have a patient who's walking around. He's 91 now with osseointegration surgery. I have the vascularization that I mentioned. I did him when he was 75, and he's now 85. I have depends on their activity level and independence. If so, there are patients who are 40, but they are very sick and they're not suitable for the surgery because they are not healthy. And there are patients who are in their 80s, but they are very healthy, very independent, and they can be very suitable for the surgery. So I don't have a particular age cutoff. I don't discriminate against age.
Okay. So a few patients have asked, where is the OPO available throughout the world now?
The OPL available in America, in Europe. I do supervise the surgeries in Poland, in Turkey, in the Middle East, in Southeast Asia, so in different places around the world. And we can direct patients if they contact us directly to the Osseointegration group of Australia Osseointegration International, and then we can direct you to the best location and clinic that you want to be receiving this technology and this service at.
I do have to emphasize here that there are groups that are directly working with us, but there are also groups that are trying to pretend to work with us, but they're actually not. Professor, can you comment on that?
Yeah, I mean, look, with every technology, copies comes out, and we have people that copied our implant in different places with variable quality. And we have a copy of the implant in India. We have a copy of the implant in Turkey. We have people that copied us in Holland. But they have variable level of experience, variable quality of product, and variable level of service afterward. So you just need to be mindful of that, and everything comes with positives and negatives. But if you directly contact our team, we'll be more than happy to help in directing you to which unit that you should go and speak to if you want to seek this kind of information.
Yep. So I guess it depends on the presentation of each patient. For more complex cases, would you recommend to come to Sydney?
Well, for more complex cases, it depends. Again, if it's a patient that requires lengthening, not many people have experience with lengthening. I mean, it's case by case basis. There is an opportunity now for us to go abroad and help with the surgeries and perform the surgeries elsewhere, like in Poland, like in Istanbul, like in the Middle East, in Dubai, in Bahrain. There is an opportunity there. In Iraq, obviously. We continue to go there often in Ukraine. But there are different centers that I go there and I help out with the surgeries and look after the patients over there. So we have different centers around the world that work directly with us and collaborate with us, or directly get involved in the treatment.
And your next scheduled trip is around October, November.
So well, I'm going to Florida in July, and then after that we go to Europe in October, basically.
Excellent. So I think we've covered a lot of the topics here. If I happen to have missed anyone, please do submit your questions in the comments.
We should do this again.
Yeah, our team will get back to you, definitely. Whether it's a more detailed consult, if the questions are a bit more direct, we'll probably recommend having a more direct consult with the professor. We can help arrange that. But if it's a generic question, our team will get back to you, definitely. Something to talk about the future with. What do you see the next big developments happening in this space?
I think the next development happening, or we are working on it already, is to have an active implant, to have an implant that can sense infection, to have an implant that can treat infection, and to have implant that is smart enough to detect any kind of stresses and tell us. Injection of technology into the implant that will be very beneficial, and we're working on that in the space. I mean, it's not interestingly enough, unfortunately, the technology of electronics is astronomically ahead of medicine. Medicine is still, relatively speaking, in the Stone Ages when it comes to technology. So it's about time that we catch up with the technology, and the reason is because we're dealing with human beings, and there is a lot of ethical dilemmas and boundaries that prevent us from implementing technology. So there is no barriers and limitation for companies to come up with new products every 5 minutes. While when it comes to medical products, it takes years and years for any changes in any kind of implant design, because of the impact that it has on the human beings, and that in itself have caused a lot of slowing in the progress of these technologies.
Amazing.
Good.
All right. So I think I've ran over time a little bit, but definitely if your questions are not covered, we'll do this again. I believe in the future we'll do one more related to your regular job as a hip and knee surgeon. We'll talk about things along the lines that you're very passionate about on the No-Gap program. Please stay tuned. We'll bring the professor in, and if you have any more questions, if you want us to do any particular topics, leave a comment and we'll definitely consider it for future topics.
Thank you very much.
Thank you
All
very
the
much.
best.